All right, I think we can go ahead and get started. I want to welcome you all to our session today, ACA Open Enrollment Season, Opportunities for MCH Programs to Promote Coverage for Parents and Children. I do really appreciate you taking the time out of your busy schedules to join us. I know there's been a sheer amount of virtual opportunities, so we're very grateful for you joining us to discuss this important topic. My name is Athia Chaudhry, and I'm a Senior Program Manager on the Health Systems Transformation team at AMCHIP, and I will be your host and moderator for today. I'll begin with a few housekeeping items. All lines will be in listen-only mode. You'll be able to unmute during the Q&A. If you have any questions for the presenters at any time, you can type those into the chat box. Please fill out the evaluation survey at the end of the call. Today's call will be recorded, so we encourage you to share among your colleagues afterwards. And if you encounter any technical difficulties, you can reach out to Jess Cohen at jcohen@amchp.org. Great. So for today, I'll begin just with a little stage setting and talking about what the ACA has meant for MCH, just trends over this past decade, and then I'll turn it over to my colleague, Stan Dorn. He's the director at the National Center for Coverage and Innovation and senior fellow at Families USA, and he'll talk a little bit about kind of open enrollment during this COVID-19 pandemic. And then we'll round out with Sarah Cariano, who's a policy specialist and lead navigator at the Virginia Poverty Law Center in the Enroll Virginia program. So by the end of today's session, we hope that you'll have an increased understanding of the ACA open enrollment season and opportunities for MCH professionals. Be able to identify one action item that MCH professionals can take to support the enrollment process in their states, and identify at least one strategy for reaching underserved populations with information about ACA marketplace coverage. So as I mentioned, I'll just do a little stage setting. So it's been over a decade since the passage of the ACA, and so that means several years of open enrollment seasons. And as you'll see on this slide, this really demonstrates the success of the ACA, and we see this decline in steady decline of uninsurance among all populations, non-elderly populations, and then particularly beginning in 2014 when Medicaid expansion and marketplace subsidies really kicked in, the decline continues more steadily. However, you'll notice that beginning in 2017, there is a slight uptick in the uninsurance rate, so 2017 through 2018, and we'll talk about a few reasons why. And these next two slides kind of look at the same data, but for specific maternal and child health populations. So this shows you kind of the story of the uninsured children from 2008 to 2018. Similarly, you see a steady decline, and in particular, beginning in 2014 through 2017, the decline is more rapid. And again, similar to all populations, children also see a slight uptick beginning in 2017 to 2018. And then zooming in on women in particular, so this chart shows you the uninsurance rate among women 19 to 64, young adult women 19 to 25, and then low income women. And again, it tells you that same story of the decline in uninsurance, and then, really we see that more rapid decline beginning in 2014. So I just, I mentioned that, there has been like this slight uptick in uninsurance, and there are many reasons why. I mean, we, since the beginning of this administration have had many attempts at repeal of the law. executive orders and congressional legislation that repealed the individual mandate. So there's been a lot of kind of slowly chipping away at the ACA. However, most relevant to our conversation today is that these past few years have brought a shortened open enrollment season. So what it used to be 3 months, so 3 whole months for the ACA open enrollment season, and now it's shortened to 6 weeks. And there's overall reduced open enrollment support. You've probably seen this in your states. I mean, very minimal dollars for navigator grants, very little advertising, in-person assistance. I think overall the programs have been slashed by over 80%, which is quite significant. So just to reflect on who are the uninsured, I mean, who remains uninsured, and of course the pandemic has changed this, somewhat, but there have been considerable gains in insurance coverage since the passage of the law. However, certain segments of the population remain uninsured. So you'll see on this chart that if we look at demographics, you'll note that Black, Hispanic, biracial individuals are disproportionately uninsured, and then men and those living in the South. And just to look at the data from another angle, from a socioeconomic perspective, you'll note that those disproportionately uninsured are individuals with less education, higher poverty, and those in certain occupations such as the service industry, maintenance, and transportation. So these two charts they just give you a national perspective of what's going on, just in terms of who remains uninsured. I mean, it might vary in your state, it might vary city by city, but overall this gives us a sense of where to target and for whom to target outreach and enrollment, education, and campaigns. So on this slide, I want to share, take a minute to share a few AMTIP resources. The first is an ACA open enrollment fact sheet that is consumer facing. So I highly encourage you to use this as a part of your outreach materials, tweet it out. It's written in lay terms for families or consumers, and it kind of walks through what the marketplace is and how to sign up and where to find local assistance. And then the second fact sheet is outreach and enrollment, which is focusing more for state Title V and MCH programs. So before we transition to the next speaker, I just wanted to pose a question to our participants. You can chat away and type away in the chat box to think about this as you're hearing our presentations. What activities is your state or local agency planning for open enrollment? And do you need additional support or resources? Please specify. And I will also type this into the chat box so you can revisit and think about this at a later time. So I will end there and turn it over to Stan to pick things up.
Hi, Atcha. How you doing?
Hey, Stan. Doing well, thank you.
Wonderful. So grateful to be here with you all today. And thank you so much, Atcha, for inviting me to join you all. Is it okay if I try to share my screen?
Yes, please.
I'll give it a shot. Here we go. All right. Now let's go here and actually start the slides. How's that? Can you all see? Excellent. So thank you so much again. I'm really excited about the opportunity to chat with you all. I think, as you'll hear, I think you're in a very good position to have a real impact on the families and children that are now at heightened risk due to both the pandemic and the economic crash that the pandemic has triggered. So the question I'm going to focus on is, first of all, who doesn't have insurance now? Atcha did a great job showing you the available survey data from past conditions, past years, but it's a moving target. People are losing jobs, people are losing health insurance. What does that look like right now? And then second, what are some strategies to make sure that people can enroll in health programs for which they qualify? So the problem we face is that the definitive national survey data for the current year, 2020, will not become available until August or September of 2021 at the earliest. That's when the Census Bureau puts out its annual health coverage numbers. And policymakers, both federal and state, really need to know now what is happening now to people's health insurance. And we don't have optimal data or anything close to that right now, which is tough. There are, to try to fill the breach, a number of organizations, including ours, tried to put out estimates saying, based on what we know from past patterns in terms of job loss and resulting loss of employer-based coverage and the transition to becoming completely uninsured, here's the number of people who we would expect to lose health insurance coverage under the current economic conditions with reduced employment. And people lose their jobs, they lose employer-based coverage. They may be able to transition to another employer plan, a spousal plan. They may be able to transition to Medicaid or the Children's Health Insurance Program, CHIP, to the private insurance market, perhaps health insurance exchanges created under the Affordable Care Act, perhaps with premium tax credits to help pay those costs, or they may not be able to transition at all and may wind up completely uninsured. How many people are we talking about? So these studies, these sort of synthetic estimates that I've listed on this table, say that essentially under current economic conditions, we would expect somewhere between 10 and 30 million workers and dependents to lose employer-based coverage, of whom between 3 million and 8.5 million would become completely uninsured. The remainder would presumably find their way onto coverage. The other sort of and comparative information suggests that these are really high coverage losses, potentially greater than the largest we've ever seen in American history, which took place in 2009 at the worst year of the Great Recession. So, but these are just estimates, synthetic estimates. We have now some real-time 2020 survey data, which is very troubling. So, health insurance industry conducted a survey of their members and said, how many people how many covered lives are there in employer-based insurance now compared to the past, compared to February when the pandemic hit? And in just 3 to 4 short months, 7.5 million people lost employer-based coverage. That includes adults, it includes children. We don't know how many became uninsured, but that number alone is really quite staggering, as you'll see. Later, the Census Bureau began conducting weekly surveys starting at the very last week in April and going through the end of July, and they picked it up at a reduced pace more recently. But for a while, they were doing regular weekly surveys, and they found that after the period covered by that health insurance industry survey, another 3 million people lost employer-based coverage. Now, that survey looked just at adults. So if we were to include children, there would be additional losses. Unlike the health insurer survey, however, this Census Bureau survey could find out about what happened to the number of uninsured in this last time period from April or May just to July. And in that period, of the 3.3 million folks adults who lost employer-based coverage, 1.4 million found their way onto other insurance, but the majority, 1.9 million, became completely uninsured. So to put this into perspective, during just the first few months since the COVID recession hit in force, through July, at least 10.8 million people lost employer-based insurance over that 6-7 month period. That is more than twice the size of the largest previous loss in employer-based coverage ever recorded from 2008 to 2009. So the situation we're in is grim. The good news is, under the ACA, most people who lose employer-based coverage will qualify for help, either through Medicaid or through advanced premium tax credits. This analysis from the Kaiser Family Foundation looks at 2 separate time periods and 2 groups of states. It looks at Medicaid expansion states and non-expansion states, and it looks at the situation in May 2020 when there was full unemployment insurance benefits paid, including the $600 a week supplement that was originally authorized by Congress back in the spring. And and what will happen in January 2021 when all the unemployment insurance goes away. Now, I don't know from reading the Kaiser study whether that was just, whether the January 2020 analysis is just about what happens once that $600 a week goes away. If it is, that's the world we're in right now. We don't have to wait till January. So, but we may be in a slightly better position than what they show in January. But all of that is sort of methodological quibble. The main point is that more than half of the uninsured who are losing coverage, or people who lose employer-based coverage, in fact, more than 70%, 70% or more, in whether it's an expansion state, non-expansion state, with or without UI, more than 70% qualify for some kind of help. So the question, though, is, will they actually receive that help? We've already seen, as I mentioned, from May through July, more than 50% became uninsured. So lots of folks aren't signing up. What is going on? Well, before we answer that question, let's talk about what it means to lose health insurance right now. This is, as you all know, it's the worst public health crisis in more than a century. It is the worst economic downturn since the 1930s, and this is not a good time to lose health insurance. So obviously, if you don't have coverage, we know there's a mountain of research out there that shows people without health insurance are literally 4 times as likely to delay seeking necessary care because of cost, or to go without such care entirely. And that increases the danger posed by COVID-19. If somebody comes down with the disease and they start experiencing symptoms, a cough, fever, limited ability to smell, we know that a lot of folks just don't get care for that, particularly if you don't have insurance and you're worried it's going to cost you a huge amount of money. You will stay home and hope you get better, and that means you are putting your health at risk, and it also means the disease is spreading to others while you wait to get care. That is not a good recipe for solving this horrible pandemic. But cancer, heart disease, asthma, diabetes, none of those conditions take a vacation when COVID-19 comes to town. And clinicians are reporting that the receipt of care for chronic illness is down substantially since COVID-19 began. And if you don't have insurance and you don't seek care for these conditions, or depression or anxiety, that means your illness is more likely to be detected at a later stage when it's harder to treat. Women with cases of breast cancer won't get that picked up until it is too late for many of them, tragically. And people who know they have chronic illnesses will, scrimp on prescriptions, not go to the doctor, and grim consequences can result, including mortality. Very, very serious consequences. And the other piece, even aside from health, is household finances. We know that right now, according to the Census Bureau data, that household pulse survey data, tens of millions of people are going without necessary food in each week, and roughly half of them are in families with children. These are surveys just of adults. We know there are more than 20 million people who are at risk of homelessness, who have no confidence or very slight confidence in their ability to make their next month's rent. There's a lot of economic insecurity out there, which will just be heightened by piling a mountain of unpaid medical bills on top of people who lose their insurance. And just to put it very grimly, more people will have to choose between seeking necessary health care and putting food on the table for their families. And that is really just an outrageous situation, but that's what we face. And as you all know, way better than I do, parents' health coverage affects children. If mom and dad are uninsured, the child is more likely to be uninsured. If mom is not getting treatment for depression, that can have lifelong consequences for that child. So we're all in this together in our families, and it's very worrisome. It's also worrisome from the standpoint of getting the economy going again. Economists tell us the most important thing we can do to revive the economy is to fight COVID-19, and that is hard to do if the number of uninsured is high and rising. So it's a very serious problem that we face. So how are we going to enroll these folks, more than 70% of whom are going to be eligible for help, into coverage? Well, the problem is that laid-off workers and their families historically have been really difficult to enroll into health coverage. And I'm going to just describe some of the grim, I hate to keep using this word grim, but that's where we are. The results have been tough so far. So in 2002, health coverage tax credits were passed. They provided 65% subsidy for private insurance, including COBRA, take-up was 10 to 20%. In 2009, the Recovery Act provided 65% subsidies for COBRA coverage, and the evaluation found no statistically significant effect on coverage. The ACA obviously provided much more generous coverage than these earlier initiatives, but even so, when I was at the Urban Institute, we found that less than 15% of people who qualified for special enrollment periods because they lost employer-based coverage through job loss, less than 15% of them signed up for insurance. The rest were uninsured. And longitudinal studies have shown that many populations benefited from the ACA, but one population that did not benefit hardly at all was people who lose employer-based coverage. Despite available help, many failed to enroll. Now, why is that? Well, it's pretty straightforward when you stop and think about it. Job loss is traumatic for many people. It is an emotional gut punch. The literature is filled with evidence of high levels of anxiety, depression, even grief when people lose their jobs, particularly in a culture like ours where self-worth is so tied up with employment. And not only that, people are focused on meeting absolute top priorities, survival. It's the old Maslow hierarchy of needs. People are focused on getting food on the table, getting the rent bill paid, keeping the lights on. And unless somebody has a known need for healthcare, a chronic condition or acute condition, health insurance just does not rise to the top of the list. And that means that very few laid-off workers have the bandwidth to learn about complicated health insurance programs and to fill out paperwork. And there's just a mountain of behavioral economics research that shows bandwidth is key to signing up for programs. If you're anxious, if you're depressed, if you're preoccupied with other things, very small procedural requirements will cause enormous reductions in participation levels. And that's exactly what we've seen with laid-off workers and health insurance. Now, the good news, to switch from out of grimness to goodness for a moment, is that we have succeeded sometimes in reaching this population. And the way we've done it is by providing very hands-on, although now socially distanced hands-on, very intense, individualized help, signing people up for coverage, filling out paperwork for them, getting authorized to solve problems proactively. And so there are two big examples of success in this very tough environment. One is the health coverage tax credit program that I mentioned to you a few moments ago that in general had a 10 to 20% take-up rate. When unions or state agencies became involved providing intensive individual assistance, completing forms, getting authorized to solve problems, diagnose them, and advocate on behalf of the consumer and solve them, the participation rate went from 10 to 20% to more than 50%. That was huge. And we can do it again. And in fact, in Kentucky, they already are doing it again. Kentucky's Medicaid program did something brilliant earlier this year that really, really worked. So now not only, just a little parenthetical note, not only laid off workers themselves, but unemployment insurance agencies have little bandwidth right now. I mean, as you all know, those poor agencies are struggling with huge caseloads. By far the largest number of applications this country's ever seen for unemployment insurance are coming in, and they're understaffed. You got to feel for those folks. So they don't have the bandwidth to take on much new stuff. They've got to focus on taking care of their knitting, as the saying goes. So Kentucky did something so smart. They had the UI agency give contact information to the Medicaid agency for everybody who received unemployment insurance UI or all UI claimants. And after that, the UI agency could just step out of the picture. They didn't have to do anything. The Medicaid agency sent email messages to all of these folks. It extended a form of presumptive eligibility for Medicaid that enabled, just a very simple application form. Who are you, social security number, etc. Basically, if you get UI, you can get Medicaid. It was the bottom line. They sent this email to everybody saying, "Hi, you probably qualify for free health insurance through Medicaid. Sign up by going here." And the link would take them to this really simple application form, just 5 or 6 questions. Bunch of people opened the emails. Very few, almost none, filled out the form, which is not a surprise to any of you, given the causal analysis that I gave you a moment ago. But what the Medicaid agency did that was brilliant was they picked up the phone and they called everyone who opened an email message indicating some interest in health coverage but did not complete the application form. And we can talk about how this works or some of the challenges and so forth. But the bottom line was that they experienced by far the biggest increase in Medicaid coverage in the country. More than 100,000 uninsured people were enrolled into Medicaid over the course of a few short months, and this worked because folks just did it over. Hi, it was just, hi, I'm here from the Kentucky Medicaid program. Well, let me sign you up over the phone. You don't have to do any paperwork yourself. It was just brilliant. So the bottom line is we can get these folks enrolled if there's somebody there to do the work for them, fill out the forms, troubleshoot the problems. So that turns to you. Individual assistance is vital, and you all are in a fantastic position, it seems to me, to work with the clients that you know well, the clients who are coming to you on a regular basis, and volunteer to help them fill out insurance forms, coverage for Medicaid. And the other piece would be, depending on your circumstances, you may be able to work with other state policymakers and find ways to put in place systems that give these folks the kinds of hands-on help, albeit cyber hands-on help, that they need to get the health coverage on which the moms, the dads, and the kids in these families so desperately depend. Thank you so much, and I'm looking forward to the conversation.
Thank you so much, Stan, for that excellent presentation and those wonderful examples. I'll turn it over to Sarah.
Just loading, hopefully. Here we go.
Here we go.
Great. Well, as Atia said, my name is Sarah Cariano, and I am a navigator. So I am one of these people who is kind of in charge or has been funded to provide that one-on-one assistance to families as they lose coverage or during open enrollment. And I, just for a little background, have been doing this since the very first open enrollment with Virginia Poverty Law Center, which is a navigator program here in Virginia. So I wanted to start with, here you can read, here's just the very kind of brief overview of what I'm going to talk about today. And I wanted to highlight just a consumer quote that we got. So this was written to in a letter to me about one of our sisters out in Southwest Virginia. And in the beginning of the letter, the consumer said, "I was tired and frustrated, not feeling well, was spending hours on the phone, not getting so much mixed information," which is a really common thing that we hear. And by the end of the letter, she, referring to our navigator, was exactly who and what I needed to understand and complete this process with an educated decision I felt good and confident with. And that really sums up what I think our job is. It's to educate consumers so that they are confident in the choice that they're making with their healthcare, and then help them with the process if they need it. So that's my little opening about who we are and why I think we're important. So again, navigators are funded through the Affordable Care Act, and Atia very nicely laid out how our funding has been cut year over year from the federal government. And so there's fewer and fewer of us out there, but I just wanted to call attention to kind of who navigators are versus these other sisters in the field that you may encounter. So again, navigators, we are federally funded through the ACA. If you have a state-based exchange, they're funded through your state exchange. A certified application counselors, any organization can sign up to be what's called a certified designated organization, or CDO. And these folks are not funded to do this work, but they have certified application counselors that do application and enrollment assistance as well. They're not required to provide community outreach like navigators are, but many do. In Virginia, we have them at all our federally qualified health centers. That's really the biggest network of CACs that we have in this state. And then there's some other organizations that do this as well. And then last, just within each of your state, there may be more specifically focused assisters. So in Virginia, our Medicaid agency actually funds a group of Medicaid assisters to focus mostly on children and pregnant women, and then the Medicaid expansion population now that we've expanded Medicaid. The Ryan White programs, we work really closely with them, helping their folks enroll in ACA or Medicaid coverage. That gets those folks, traditionally the Ryan White programs just cover the HIV related care, and so this is a nice partnership because they get full comprehensive care through an ACA plan, and then the Ryan White programs spend less money on the medication and can cover more people. The hospitals all have workers. There's agents and brokers if someone is ACA. Not a lot of agents and brokers know a lot about Medicaid, so knowing kind of what people might be able to be assisted by those folks and who wouldn't is helpful. And then I just threw it on here because we work with a lot of people who are transitioning, as well as, you know, there are some women who have a disability who are in Medicare, so knowing that they're Medicare sisters, federally funded through the state health insurance program could be important as well if you work with some of those women. So our specific project has been funded since the very first open enrollment. Up until just this August, we were federally funded, and then Virginia has opted into becoming a state-based exchange over the next few years. And so we began our being state funded September. So I'm kind of in a unique position where I've worked in a state where we've been in a lot of different situations, and so I'm more than happy to talk to people about specifics now or outside the webinar about what if my state has this or this or this, because I've kind of worked in them all at this point, because Virginia's just transitioned between the different things. And our main goal, our main job is to provide free and unbiased assistance with the ACA, Medicaid, and CHIP. We do outreach and education. So prior to COVID, we were in the community a lot. It's a little scaled back at this moment. The enrollment assistance, so one-on-one, in-person, virtual, over the phone. We do a lot of complex case help and appeals. Folks sometimes think our work is just during open enrollment, but we actually do quite a lot of work outside open enrollment as people have challenges, as they transition, they need to do an appeal. As Stan said, so many folks who lose coverage, we can help them at that point. So it really is a year-round work if you want it to be. There's plenty of work to do all 12 months. And then we do provide some information and help during tax time. We're not allowed to give tax advice, but we can help folks understand the tax implications of the ACA and the tax forms that they've gotten if they've received tax credits. Our specific program also works really closely with the CACs in Virginia. We provide complex case help for them. And this is the one crucial thing I really love to call about navigator programs, is I think there's a lot of people who either focus on, you know, Medicaid, and some folks who focus on the marketplace. We're kind of uniquely positioned to understand both systems and where they interact, which can be really helpful to prevent churn between the programs or people losing coverage when they're moving from one to the other. And I'm not going to read this to you, but a lot of our work is done through partnerships. So we are a small team. Even with our enhanced state funding, we're going to be about 20 people statewide. And so much of our work is really predicated on having strong partnerships in the community so that we can reach community members. And also having been in the community for so many years. The ACA is not, depending on your leaning, has not always been welcome in all parts of our state. And just having someone in the community year over year, all of a sudden it's like, oh, Marcy's a health insurance woman, you can go to her. So just being that physical presence that year over year is providing help, honest, true information, and really just being kind of steadfast in your community has been very helpful for us as well. And then getting to know our local media, particularly with our non-English speaking communities, so like the Spanish speaking radio, has been really crucial for us to getting messaging and really accurate information out to that community about open enrollment and SAPs and Medicaid and all of those things. And on that note, I wanted to speak a little bit more in depth about reaching, how we kind of reach with our vulnerable populations with a little bit of a maternal child health lens on it. So first, we do a lot of work with non-citizens, and I think we tend to work a lot with this community because the eligibility rules are so much more complex for them within Medicaid and the ACA. I won't necessarily go into detail about this, but again, I'm more than happy to answer questions if anyone does want a little more detail about them. And then there's also public charge, which is this federal rule that has instilled a great deal of fear in the community, in the non-citizen community, about being able to change status, become an legal permanent resident, help your family immigrate if that is what you want, if you've had the receipt of a public benefit. And so we've seen folks who are eligible where public charge would not affect them actually pulling their children out of coverage or dropping coverage. And so that's been a really big consideration for this community as well that we've tried to work with. The homeless population is challenging. Just in Virginia, at least, our Medicaid agency communicates virtually exclusively via mail. And obviously that is challenging if someone does not have a permanent address. And then when mail gets returned or something is not responded, that person's coverage gets immediately terminated. And that causes a lot of gaps in coverage and loss of coverage for someone who is eligible. They just didn't clear whatever that bureaucratic red tape was to complete that form or update their address. You don't have address, you can't update it, things like that. In the rural parts of the states, we certainly, especially this year, where we are so reliant on technology, you know, the western part of our state, there's areas where even cell phone reception is not good. And so doing a phone, I mean, not even doing like a virtual appointment, doing a phone appointment is even challenging. So really understanding the challenges that your community may face with that, and not just assuming that, oh, they can just call this number, oh, they can just get it done this way, because a lot of times people just don't have capacity to do that. The infrastructure isn't there for them. And our main takeaways are just always listening to the community. You know, I may assume that I know what your challenge is, but I likely don't. I haven't walked in your shoes, and so my first job is to sit down and listen and understand what you're going through and what your challenges are, and then we can work together to try to overcome them. Always showing respect and asking questions. You know, in the Richmond community, we have a decent Vietnamese immigrant community, and I've worked with them a lot, and I have had families who, you know, bring their friends and family because they say when we've gone to the DSS, the local office, they don't feel respected, and so they don't want to go there for help. So there's a lot that I don't know about that culture, but I think just sitting and listening and showing just general respect for folks is simple but big. Being patient, you know, I can say, I know you need this right now, but until that person or that community kind of understands and says, like, this is a need I have, then we can meet and move forward. But I can't force someone to like see my priority as their priority. It has to be their priority. As Dan was saying, you know, when folks lose their job, health insurance isn't always their priority because they have all these other things going on. And so I can't, you know, that's their priority. I have to respect that. And then last, it kind of fits on the slide, and it's a bit of a thumb sticking out, but it's not just getting coverage, but keeping it. I think especially with our vulnerable populations, you know, we assume, okay, I got you covered, you're good, but there's renewal, there's changes, circumstances, there's, you know, people getting evicted right now and changing addresses and transients and all of these things. It's a process that continues on to get and maintain coverage. It's not just getting it and getting that first application in. We really need to walk side by side and understand that, you know, folks are going to need help now, but possibly down the road as well. And so just change a little bit and start talking about the actual enrollment process and why it's hard for people to do on their own. So this is a CMS flyer. This is what they say enrollment is, you know, quick and easy. You create an account, you apply, you pick a plan, you enroll, you are done. Don't let the next slide scare you. I'm not going to go through it box by box. But in my experience, this is actually what the enrollment process is. It's much more complex. There's identity verification. There's interchange between Marketplace and Medicaid. So you'll hear sometimes that there's a no wrong door policy, which means whether you apply at your state Medicaid agency or the Marketplace, you should end up where you're eligible. That process is really complex and really messy, and a lot of people get just lost in the mix there if they apply at the place where they're not kind of going to end up being eligible. And so, you know, in-person assistance, to Stan's point, is helpful, because when someone is sitting and looking at this process and they're worried about their kids and their rent and all these other things, it's just overwhelming and it's easy to walk away from because there's just so many other priorities. And so all that to be said, you know, what are the time frames for assistance? So we all know that open enrollment is coming up, and that's a big one. So we can help, you know, get a lot of people, especially these anyone who's kind of recently lost their coverage, but maybe one spouse is still working and they're a little higher income, so they're above Medicaid. Getting them into a Marketplace plan starting January 1 would be from November 1st to November 15th. And I caveat that with, this is for the federal exchange for states that use healthcare.gov. If you have a state-based exchange, there's a good chance you have a longer open enrollment, and you'll just have to look into your state to see what those dates are. Then there are special enrollment periods. So a special enrollment period is when you have a qualifying life event. So something changes in your life that makes you eligible to purchase coverage outside of open enrollment. The most common one is loss of coverage. Other ones, maybe if you have a child, you can add that child to your family. If you move into an area where there's different coverage options, you can change plans. So different special enrollment periods are times when people can get ACA coverage outside of open enrollment. And then when anyone is changing in eligibility. So a lot of folks now have decreased income and are newly Medicaid eligible, especially in Medicaid expansion states. And so we want to catch those people instead of just letting them become uninsured, getting them into another program that'll give them comprehensive coverage. Pregnancy and postpartum coverage for Medicaid, those income limits are higher than regular adult Medicaid for individuals who are not pregnant and not in their postpartum period. And so someone may be below, if you're in a Medicaid expansion state, above that, and then become eligible. And then in our non-expansion states, you know, there's a good chance a woman who is working a minimum wage job is in the Medicaid gap. She doesn't have an option for coverage. And if she becomes pregnant, we should work to get her into that Medicaid-based coverage as quickly as possible so we can get that prenatal care started as quickly as possible. And then in most states, you lose that postpartum, you use that pregnancy-related Medicaid 60 days postpartum. And I don't know any woman, I've had 2 kids, who was totally good after pregnancy after 60 days. I think care needs go beyond that. And so making sure they can either transition into the marketplace or into a different form of coverage at that 60 days, not just that coverage ends completely for that woman who now has a 2-month-old and no health care. Aging out of the Medicaid system, so the categories have different ages. So when a child turns 19, they'd have to qualify as an adult. And so depending on the different income limits for those categories, they may have to go into the marketplace, they may have to go into a different Medicaid category. Also turning 65, which I know isn't necessarily the population that this group works with, but it changes your eligibility. And then you're changing immigration status. And again, the immigration status rules for Medicaid and Marketplace are really complex. But if someone has a change in immigration status, it may change which program they're eligible for, even if nothing else changes. And so just keeping an eye on that if you're working with a non-citizen community to make sure folks are getting the help that they are eligible for. There's also renewals every year, which can be kind of complex for folks. So Medicaid does have, in Virginia, it's an annual renewal process. I know some other states will check data more frequently than that, which has caused losses of coverage, particularly in children. We've seen that happen recently. So knowing the Medicaid renewal process and keeping an eye on folks, and if they lose coverage during that process, hooking them up with an assister so they can get back in as quickly as possible. And anytime you see an uninsured patient or anyone has a question about their coverage, you know, find a local assister. They can help answer. And even if it's not, you know, okay, you're ACA and it's not open enrollment, but let's make a plan for open enrollment so we can get you in coverage as soon as we can. And just a note and a reminder, Medicaid enrollment is year-round. So we don't have to wait for any kind of special period or open enrollment. We can go ahead and get folks enrolled if they're eligible just as soon as we can. Yeah. There we go. And so how do you find folks like me? So if you're lucky enough to be in Virginia, my contact information is here. Just go ahead and give me a call. I'm happy to help you. But if you are not in Virginia, you kind of have to figure out if your state is a federally facilitated marketplace. So if you use healthcare.gov, for the most part, or if you're a state-based exchange or a state-based exchange that uses the federal platform. So states like Virginia right now that are transitioning from a FFM to a state-based exchange, we have a couple-year period where we're a state-based exchange where the state is taking over some aspects of the ACA, but we're still going to use healthcare.gov. And so those states, it may be tricky to find out. And on my next slide, I have a resource where you can find that out. But so what kind of state are you? If you're a state that uses healthcare.gov, I have 2 links here. One is the Navigator Awards. I actually find that sometimes the simplest way to just find what organizations have been funded to do this work. You can also find the local help tool on healthcare.gov. That one also lists brokers, and so I'll show you how to filter to make sure you're getting just to sisters. Again, particularly if it's someone who may be eligible for Medicaid, we want to make sure they get to someone who's familiar with the Medicaid program in your state. And then those state-based exchanges, so it's funded through the state. So there's the good news is that you probably have more assistance available in your state. Maryland has a lot more assistance available than Virginia has, because Maryland's had a state-based exchange for quite a while, and Virginia is just moving into it this year. The certified does, so those CAC organizations are also regulated by the state, and so you would either need to go to your state-based exchange or find the entity that funds them, and then you can find the list of those organizations. And this is the local help tool on healthcare.gov. I just want to say, when we first put in your zip code, it'll pull up the full list, and there's 2 filters that are automatically populated on it: agents and brokers and assisters. If you want just assisters, which are going to be your navigators and CACs, just cancel out the agent broker one, and you'll get just the list of the assisters. It's not intuitive, so I just wanted to point that out. And then, so this is my last little bit about just resources for knowing what's going on in your state. So the first link there will show, it's a chart, like Kaiser Family Foundation is wonderful. They have charts for just about anything you can want to chart for. So if it's not here and it's something you want to know, it's a really great place to start. So this first link, I'll tell you if you're a state-based exchange, a federally facilitated marketplace exchange, which is healthcare.gov, or a state-based that's using the federal, and that'll help you kind of figure out where to start looking for who your assisters are. And then the last 2 slides we're just going to give you some basic information about your Medicaid program if you don't know a whole lot about the income thresholds. There's a common saying, if you know one state's Medicaid program, you know one state's Medicaid program. States are given a great deal of flexibility, and so important to know the income thresholds for pregnant women and children, as well as the length of postpartum coverage. Some states have expanded it, and so these are some simple tools just to go and look. And so if you have, a patient and have a general idea of their income, you can kind of get a good idea of where you think they would fall Medicaid versus the marketplace. And that is all I have for you today. So I hope that was helpful. I'm sorry if I spoke too quickly. I tend to get that feedback. But I'm happy to take any questions. And again, here's my contact information. So feel free to reach out to me individually if you have a specific case or specific question that you want to talk through.
Great, thank you so much, Sarah and Stan, for this excellent presentation. So we can open it up for questions from our attendees. You can unmute yourself or type your question into the chat box. I'm going to see if there was already a question. There is a question for Stan. The MCH community is very concerned about loss of coverage for women of reproductive age, 18 to 44. Is there any gender and age-based data on coverage loss?
Not in 2020. For coverage loss, no. The health insurance industry survey doesn't provide that data at all. The Census Bureau Household Pulse Survey doesn't report that data, but microdata are available, and we could take a look at that. And it would be tough to talk about the changes, the number of people who've lost coverage, but we could try to break out, according to the HPC, that what the current characteristics are of uninsured adults and how many of them are women under age 45. So we can try to take a look at that, if that would be important.
Thank you, Stan. Any other questions? Please feel free to unmute yourself. Any thoughts or reactions?
Yeah, I just wanted to make sure you saw the question in the Q&A from Greta. Are there initiatives to encourage the participation of Black residents, trends, and coverage?
Thank you for pointing that out, Jess. Right, so I'm just going to repeat the question again. This is from Greta. Are there initiatives to encourage the participation of Black residents, trends, and coverage?
Well, so I can say a little bit about the losses in coverage that have taken place in communities of color. They have been disproportionate. We did an analysis looking at household pulse survey data and found huge losses among African Americans in general. The Urban Institute looked at household pulse survey data, and they found major losses among Latinx folks. The health insurance industry surveys did look at issues of race and ethnicity and found significant adverse impact for Latinos and African Americans. So the harms are there, which is not at all a surprise. And when you think about who is losing their jobs, it's disproportionately people in low wage, frontline jobs, people who can't work from home, and that has, disparate adverse impact. So it's not a surprise. It's horrible, but it's not a surprise. In terms of specific initiatives targeting African American women or African American communities, I'm not aware of any. I mean, I have to be really candid with you. Other than what I told you about Kentucky doing, I haven't seen much that is really worth writing home about. It's so sad. I mean, we analyzed most state unemployment insurance websites, and they don't talk about health insurance in most cases. When they do, it's outdated and incomplete information in almost all cases. It's really problematic. I mean, the very best that states are doing, other than Kentucky's brilliant initiative, the very best that states are doing is just sending information to unemployment insurance recipients and saying, well, go over here and apply for health insurance. And I don't think that's going to do very much. It will help some people, but not that much. So unfortunately, what that means is, the good way of looking at it is, the field is clear for everybody in this call to develop brilliant, innovative initiatives to reach these communities. And if you do, let us know and we'll spread the word.
Yeah, and I would encourage you also just to look into your state, like a sister community or things like that. So there might be kind of micro interventions that are happening that we're less aware of. And I will also add, I know this disparity in maternal child health was a really big driving factor in a lot of the policy changes that Virginia was really looking to implement through last year's General Assembly. So Virginia we were hoping to extend postpartum coverage 12 months. We had some budget issues, which is why it didn't go into effect. But so that was one, some more home visiting dollars, some more potential doula coverage. And a lot of that was targeted because of maternal child health and particularly the disparities within maternal child health in Virginia. And so that could be a place as well to look for work being done, as well as potential interventions. So extending CHIP coverage, so more to a higher income threshold, could be a potentially a good thing to just get more women covered and get more children covered. And obviously all of those interventions are broad-based, but they're going to impact the communities that are being most impacted poorly right now, right? Like, we have more uninsured African and Blacks and Latinx people in Virginia. So when we get higher Medicaid coverage, it's going to cover a larger portion of that community and hopefully help bring down those disparities. And for non-expansion states, I think Medicaid expansion is huge, right? Like, you're far more likely to have a healthy pregnancy if you're getting care before and between your pregnancies, not just when you find out you're pregnant 12 weeks in or whenever. And so, getting care in those before and in between times is really important. And Medicaid expansion in Virginia has really helped us with that.
Thank you, Sarah. We have two more questions, one in the chat. Are there programs that help families, single-parent households that fall in wage gaps? Example, marketplace plans may still be very expensive on part-time employment wages, but they do not qualify for Medicaid because of income.
Again, that may be state by state. So, I think we're really talking about folks who maybe are 200, maybe more 250 and up of income, where the cost of a exchange plan at the percentage, even with tax credits, they may feel is too expensive for them, for their family. If they go over 400% and they're getting no tax credits, I don't think anyone would argue that those plans are affordable. They're incredibly expensive. And so some states are have done some supplemental tax credits or things like that. We look a lot with some of our free health clinics and federally qualified health centers have increased their sliding scale to help cover those underinsured people or uninsured due to affordability. But again, it's in our hospitals as well. Some of our hospitals as well have actually increased their financial assistance for those folks, in the recognition that as more people have gotten covered, the pain points of underinsurance have become more prominent. But I don't think there's, and stand correct me, right now, any kind of national level intervention for those folks.
No, there's not. But I mean, a couple things. One is, I agree with everything that Sarah just said. I almost always agree with everything Sarah says. But then we haven't worked together all that much lately. But I think in addition to people at relatively high income levels having trouble in the marketplace, I think it's also true at the lower end of the income scale. People just above 100% of poverty in a non-expansion state like Alabama, people above 138% of poverty in an expansion state. At 138% of poverty, it costs you about $50 a month if you're a single adult for coverage. And that's a lot of money for somebody who's just barely making ends meet. And in fact, the percentage of uninsured is higher at lower income levels where there are tax credits than at higher income levels where there are not. So it's a really serious problem that you're pointing to. There are state initiatives underway to help these folks. So in Massachusetts, for example, and Vermont, they provide supplemental subsidies to make coverage more affordable, even at the lower income scale. There's an initiative called Basic Health Program, which New York and Minnesota have implemented, which has made coverage really so much more affordable for low-income people, up to 200% of the federal poverty level. In New York, for example, you get zero deductible insurance for $20 a month or less. So there are things that states can do, and there are things that localities can do as well. So Harris County, Texas, for example, has this essentially a hospital sponsorship program where the hospital pays the premium tax credit consumer share for uninsured folks up to, say, 150% of the poverty level. There's a big return on investment for the hospital, because that way these folks, instead of being uninsured, have private insurance through the marketplace. It is such an incredibly efficient way to go. The hospital spends $50 a month for somebody who comes to them from time to time, and that draws down, $800 or $1,000 a month in federal premium tax credits. So Harris County has done it. Dane County, Wisconsin, in the private sector has done it. Like, some United Ways around the country have done that. So if you're in a state where state government is not terribly receptive to these kinds of things, you may be able to look to a county that can help provide these small resources to draw down a lot more federal resources, or go to the private sector. And to get the donations from the hospitals, it's a win-win. It's a positive return on investment for them, and it's a way to get health coverage for people who really need it.
And I would just add, just as an aside, for those folks who are so price sensitive, which is most people, make sure when they're enrolling they look at more than just premium, though. The cost of a plan is not always just the premium. And I think often we'd see people come to us with these bronze plans because they were really cheap, but they had a lot of healthcare needs. And they had really, really high deductibles, whereas they were low enough income where they would have gotten what are called cost sharing reductions, so extra help in the silver plans that bring down your deductibles. And they didn't enroll in that plan because it was, whatever more a month, but in the long run, it would have saved them like thousands of dollars. And so just the cheapest premium isn't always the best plan. And so that's just an aside and a plug to make sure you're looking at all the plan details before you decide, or send them to someone like me who will happily help them with that.
Thank you, Sarah. And one more question. Is doula coverage available in marketplace plans?
No, and I think maybe only in California, maybe in New York for Medicaid. So generally not, but there are some other states who are looking at it. We have a study this year, and so it could be a Medicaid benefit if the state chose to add it.
Thank you. We are at the hour, so I want to thank Stan and Sarah again for joining us for this wonderful conversation. Reminder to participants that all the materials are available in the Dropbox link, so the slides, speaker bios, and a few handouts. and to please fill out the evaluation that pops up after this. And we'll send a follow-up email to all participants with additional resources. I know that was one of the requests from the chat, so we'll compile more resources to share with you all, and want to thank you again for joining us. Take care, everyone, and be well.
Thank you.
Thank you, everyone.